Pharmacology SAQ6 lists agents that can cause reduction in bronchomotor tone and explain their mechanisms of action. 10 marks. These includes beta agonists, anticholinergic agents, methylxanthines such as theophylline, magnesium sulfate, nitric oxide, IV anesthetics, and volatile anesthetic agents, glucocorticoids, mast cell stabilizers, leukotriene antagonists, and anti-IgE antibodies are anti-inflammatory rather than bronchodilatory agents. Beta-2 agonists. Examples include salbutamol, terbutaline, and adrenaline. By mimicking catecholamines, beta-2 agonists activate beta-2 adrenergic receptor, which leads to activation of GS protein and the effector adenylyl cyclase, which increases intracellular cAMP via hydrolysis of ATP. Elevated cAMP concentration serves to activate cAMP-dependent protein kinase A, which can phosphorylate intracellular substrates to modulate various effects within the cell. In airway smooth muscles, pKa acts to phosphorylate GQ-coupled receptors, leading to a cascade of intracellular signals, leading to reduced intracellular calcium and decreases the sensitivity to calcium. The change in calcium concentration results in the inhibition of myosin light chain phosphorylation, subsequently preventing airway smooth muscle contraction. Beta-2 agonists also inhibits mediator release from mast cells, inhibits TNF-alpha release from monocytes, and increase mucus clearance by action on cilia. Anticholinergic agents such as ipratropium cause bronchodilation by non-specific cholinergic muscarinic M1 to M5 receptor antagonism, and this inhibits acetylcholine-mediated bronchospasm. They are useful as the vagal tone is primarily responsible for bronchomotor tone. Removal of parasympathetic nervous system effects causes bronchodilation. Muscarinic receptors in airways includes M1 and M3, which are responsible for bronchoconstriction and mucus production. ACH binds to M1 or M3 and activates GQ-PCR. cGMP increases, which activates phospholipase C to produce IP3. Calcium influx occurs, which activates myosin light chain kinase, and this causes bronchoconstriction. M2 receptors are present in postganglionic cells and limits ACH release. M2 receptors are coupled to GI-PCR. They limit vagally mediated bronchoconstriction. Extra information: M1, M3, and M5 are coupled to GQ-PCR. M2 and M4 receptors are coupled to GI-PCR. Antimuscarinics competitively block all muscarinic receptors in the airway. Methylxanthines. Example includes theophylline. Multiple mechanism of action. Predominant effect unsure. Non-specific inhibition of phosphodiesterase PDE3 and 4 isozyme that degrades cAMP to AMP. This increases cAMP and cGMP concentrations in the cell and results in smooth muscle relaxation. However, this only occurs at high doses. Methylxanthines also competitively antagonizes adenosine at adenosine 1 and adenosine 2 receptors. This inhibits the release of histamine and leukotrienes from mast cells and causes bronchodilation. Via the same pathway, methylxanthines also facilitate catecholamine release from adrenal medulla. Methylxanthines have anti-inflammatory effects by inhibiting PDE type 4. Methylxanthines activate histone deacetylase, and this reverses resistance to steroids. Methylxanthines have direct respiratory stimulant effects, which is beneficial in patients with CO2 retention by increasing CO2 washout. Methylxanthines increase the strength of diaphragm contraction. Magnesium sulfate. Exact mechanism of action is incompletely understood. Magnesium relaxes smooth muscle and hence may cause bronchodilation by competing with calcium for binding sites on the sarcoplasmic reticulum, and this inhibits calcium release, which is required for smooth muscle contraction. High extracellular magnesium results in high intracellular magnesium. This inhibits calcium influx through voltage-dependent calcium channels. Magnesium inhibits NMDA receptors, and this reduces calcium influx across the smooth muscle cell membrane. Magnesium causes bronchodilation via modulation of calcium ion flow, which inhibits the release of acetylcholine from nerve terminals. Magnesium also stabilizes T cells, preventing their activation, and inhibits mastocyte degranulation, therefore limiting the production of inflammatory mediators, which can cause bronchospasm. Magnesium sulfate also acts to stimulate nitric oxide, which can cause bronchodilation. Magnesium also increases prostacyclin production, possibly reducing the severity of asthma. Nitric oxide. Nitric oxide causes bronchodilation via smooth muscle relaxation of airways, via cyclic GMP regulation and NANC nerve activation. IV anesthetic agents. Ketamine and propofol. Ketamine causes bronchodilation by antagonizing the effects of acetylcholine and serotonin at bronchial tree. Ketamine leads to an increase in endogenous catecholamine levels, which may bind to beta receptors and cause smooth muscle relaxation and bronchodilation. Propofol reduces vagotone. Propofol has direct effects on muscarinic receptors by interfering with cellular signaling and inhibiting calcium mobilization. Volatile anesthetic agents. Exact mechanism unsure. Volatile anesthetics relax airway smooth muscle via voltage-gated calcium channel blockade, depletion of calcium stores in the sarcoplasmic reticulum, reduced calcium sensitivity of airway smooth muscle mediated by PKC, potentiation of GABAergic mechanisms, reduction of acetylcholine release from parasympathetic nerve fibers. Volatile anesthetics also have anti-inflammatory effects on airway epithelial cells mediated by GABA-A receptor potentiation. Unlike other volatile anesthetics, bronchodilatory effects are not observed with desflurane.